Guys, visible?
Yeah.
Yes, and we're taking live. Just wait 1 minute.
It's live. Shall I start, ma'am?
Yes.
Wait, Suman. Wait.
Live first star one.
Yes, we can go live now.
Shall I start now?
Suman, you can start.
So, very good evening, madam. Shuman, on behalf of Shield Healthcare, welcoming you all in today's webinar. And the topic of today's webinar is a new perspective in diagnosis and treatment of polycystic ovarian syndrome. And today's our guest speaker is Dr. Vandana Gupta, madam. Before moving into the webinar, let's have a look on our Shield Connect page. This is our Shield Connect page. Here you can find different blogs written by many different topics. As you can see, cognition and cerebral palsy, respiratory, and many more beware of health issues and common PCOS, and many more. And these are the past webinars already we have conducted in our platform and in various topics, many eminent doctors across India. And this is the very new thing, that is COVID-19 awareness update. Here you can find different blogs related to the COVID in this COVID era time. And these are the PCOS awareness blog. You can find different talks on PCOS only. There are some regional languages you can see, that is Tamil, Hindi, Malayalam, Telugu, and many more. And the most important thing is our key opinion leaders. Currently, 50 to 300 doctors are currently supporting us in our this platform, Shield Connect. And request participants, please look into the website, as it is a very informative it's related to our subject expertise area. And now it's time to start our webinar, and it's my honor to introduce Madam. Madam is a senior consultant obstetrics and gynecology, Max Hospital, Patparganj, RK Hospital, Apex City Hospital, and she is the vice president of Delhi Gynae Forum East, and is a member of reproductive and endocrinology AOGT. Madam is having the membership of IMA, EDB, Delhi Gynae Forum East, Indian Fertility Society, Society of Midlife Management, NAR, CHI, AOGT, FOXY, and ICOG. Apart from that, Madam has many awards to her credit. Dr. G.P. Rawat Memorial Gold Medal for Obstetrics and Gynae, Mrs. Vajir Singh Chaudhary Silver Award for Obstetrics and Gynae, Doctor's Day Appreciation Award in DGF 2015, Abdul Kalam Appreciation Award in DGF 2016, DMA Distinguished Service Award in 2016, and Madam received IMA EDB Excellence Award in 17. She is the owner of President Appreciation Award in WOW India 2017 and IMA EDB 2017. Madam is the academic. Madam has some academic activities as well. She has presented many lectures and papers at various conferences and chaired many sessions as conferences and conducted educational activities for FOXY in various schools and and a special interest in infertility, adolescent health, endocrinology, emergency obstetrics, medical clinic, and colposcopy. So with this short introduction, I request Madam to take over the session, and meanwhile, I request all the participants for their active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the program will be there, we shall have a short discussion with this topic with Madam. So thank you, Madam, and over to you, ma'am.
Thank you for those kind words. So I'm starting to share my screen, and today we are talking about PCOS, and this is a very, very common disorder, and we have been discussing about it in so many forums and in so many ways, but every time something new can come up, and that is what we are looking at, newer perspectives in diagnosis and treatment of PCOS. So get full screen. My slides are visible, I hope. Yeah.
Yes, ma'am.
So
Yes, ma'am.
overview is it affects about 6 to 15% and of women of reproductive years, and in hyperandrogenism around 72 to 84% are due to PCOS. And there is no prevalence data in adolescents, but we know in adolescents it is spreading like wildfire. Many of the adolescents visiting our clinic are suffering from PCOS. So the brief history, it was discovered by Steen-Leventhal. It was called Steen-Leventhal syndrome in 1935. And its understanding as a reproductive disorder was characterized by oligoamenorrhea, hirsutism, and polycystic ovarian morphology. And this understanding stays the same even today. These are the symptoms on which the diagnosis is based. So bilateral wedge resection came for enlarged ovaries as a therapeutic treatment in normalizing the menses and fertility of the woman. And hence the disorder was known as polycystic ovarian disease. And 30 years ago, it was first reported that women with PCOS had hyperinsulinism or hyperinsulinemia. And currently we are staying with the same. Research indicated that PCOS was associated with a unique disorder of insulin action, as well as defects in insulin secretion. So we are looking at the causes of hyperinsulinemia, which could be a disorder of insulin functioning or insulin secretion. And together, these abnormalities confer a substantially increased risk of glucose intolerance. So in epidemiology, it is the most common endocrine disorders affecting women of reproductive age, and 8 to 11% of reproductive, or 6 to 15% of reproductive age group women suffer from this. Most common cause of anovulatory infertility, to the tune of 70 to 80%. And Indians have among the highest prevalence rates in the world because we are a diabetic capital as well. That is no wonder PCOS is very, very common, nearly 41% in reproductive age group. So it is an epidemic in India. There is 41% prevalence. 1 in every 5 women is suffering, and 116 million patients as of today, and it is rising every day. So these are the manifestation, the main clinical and metabolic manifestations of polycystic ovarian disease according to women's stage of life. So clinical manifestation of PCOS appear in adolescent, but the disease seems to be originating in the intrauterine environment through developmental programming. So there is a fetal programming, maybe an IUGR, and the baby is born small for gestational age. Insulin resistant when she's in toddler, there will be insulin resistance, adipose tissue dysfunction, excessive postnatal catch of weight gain, premature adrenarche, pubarche, and menarche. And when she is an adolescent, there is weight excess, visceral adiposity, irregular periods, or anovulation, acne, seborrhea, hyperandrogenism, and hirsutism. And when she is of a reproductive age group, then there is obesity, carbohydrate intolerance, dyslipidemia, infertility, and pregnancy complication. And if this doesn't leave her in reproductive age also, then later on in life, type 2 diabetes, dyslipidemia, cardiovascular disease, arterial hypertension, endometrial cancer. So basically it is associated with metabolic syndrome and its comorbidities. So again, if these are the same thing we are seeing as predisposing factors in utero programming, childhood, increase these are the different presentations. In increased AMH levels in prepubertal years, at puberty, there will be premature adrenarche, menarche, and hyperandrogenism, increased GnRH pulse frequency, and increased AMH levels and ovarian volume, and hyperinsulinemia. And then in reproductive years, irregular cycle, again hyperandrogenism, subfertility, infertility, increased AMH and antral follicle count, and glucose intolerance and insulin resistance. That seems to be the prime suspect nowadays. And postmenopausal, again, increased prevalence of hypertension and increased triglycerides, metabolic syndrome and its comorbidities. So phenotypes of, these are the different phenotypes across the lifespan of a woman. And again, it is the natural history in the fetal life. Maternal hyperandrogenism is the one which is programming the baby. Then we have a baby with a lower neonatal weight, which catches up in adolescent, premature adrenarche, and clinical hyperandrogenism with infertility and irregular menses. And childbearing age, she might be suffering from this diabetes, dyslipidemia, high blood pressure, and obesity. And menopause, she becomes exposed to metabolic syndrome and its comorbidities. as well as endometrial carcinoma and breast cancer. So diagnosis is, we know we are following Rotterdam criteria. Any of the two should be there. In adolescents, we want all the three criteria to be there. Although new thinking is that no ultrasound should be done before 8 years have elapsed since puberty. So practically, if we think to be puberty to be 12 years, then 8 years means 20 years. So at least we have already jumped from adolescent phase to an adult phase. So the findings would be hyperandrogenism, oligomenorrhea, and polycystic ovaries. Any two are required in Rotterdam criteria. Hyperandrogenism can be clinical or biochemical. And these are the diagnoses when the patient comes to you with these presenting symptoms. If they are present, then if she's come as an amenorrhea, then consider serum androgen test and or ovarian ultrasonography. If abnormal result will lead to the diagnosis. If findings meet the criteria for PCOS, then perform pregnancy test if she's amenorrheic. Measure serum TSH when we consider thyroid dysfunction, prolactin when we suspect hyperprolactinemia, and 17-hydroxyprogesterone to rule out non-classical congenital adrenal hyperplasia. If these are normals, because the diagnosis is a diagnosis of exclusion. So we are trying to exclude all these diseases, low body weight, eating disorder, or excessive exercise. We are measuring LH and FSH and estradiol to rule out hypothalamic amenorrhea. And we measure serum FSH and estradiol to rule out primary ovarian insufficiency. And if she presents with severe virilization, changes in voice and clypedomegaly, we measure total testosterone and DHEAS and then perform ultrasonography of ovaries and CT or MRI, secreting tumor, and we rule out kind of Cushing syndrome if the patient is present purpose try and hypertension. We measure salivary or urinary cortisol and perform dexamethasone suppression test, and we are ruling out Cushing's. And then we have to rule out acromegaly if there is a change in hat size or glove size, protruding jaw, and impaired vision. So it is overlapping. The symptoms are overlapping so many diseases which appear as differential diagnosis, but basically you have to rule out these diseases and then put her as polycystic. Proceed with the screening, checking the BP and lipid panel and 2-hour OGTT obstructive sleep apnea and overweight patients. So again, these are the same phenotypes according to the childhood and the early adolescence, early menarche. In adolescence, she will have irregular menses, hirsutism, overweight, increased testosterone and LH, and mild metabolic abnormalities, because this is the beginning of metabolic syndrome. In late adolescence, it's the same irregular cycles, hirsutism, persistent hyperandrogenemia, overweight, and metabolic alterations, which are establishing themselves at this time. And in adult fertile age group, hyperandrogenism in the form of hirsutism, acne, or alopecia, hyperandrogenemia demonstrated in the blood parameters, irregular menses, maybe oligo or amenorrhea, infertility, overweight, and features of metabolic syndrome and type 2 diabetes, and polycystic features at an ultrasound. In postmenopause, we might still get polycystic features at ultrasound, but although the ovaries become atrophic at that time, mild hyperandrogenemia, metabolic alterations are the main thing in postmenopause. We are looking at metabolic alterations and what we are looking at, hyperandrogenism can be a non-obese patient, non-insulin resistant, and can be an extreme obese women with insulin resistance and hyperandrogenism. So it has a full spectrum. It can go from here to here. So when the presentations are severe, she has all the presentations: bleeding, irregular bleeding, polycystic ovarian, pictures, and high androgen, low insulin, and frequency. And when we have irregular bleeding with the polycystic ovary or no polycystic ovaries on ultrasound, high androgens and insulin resistance, which is present in around, we see the frequency to be around 7%. When there is an ovulatory polycystic ovarian disease, then the bleeding would be regular because she's ovulating, Morphology can be polycystic on ultrasound. Androgens are high, insulin is high, and presentation is seen in around 16% of women. And in another 16%, we have mild non-hyperandrogenemia. And in here, the bleeding might be irregular. PCOS morphology can't be seen on ultrasound. Androgens are minimally increased. Insulin might be normal, and we see this presentation in another 16% of the women. So this is another way of presenting how the patient is presenting with different disorders: the hyperandrogenism, hirsutism, oligonuria, and polycystic ovarian disease. All are present. Maybe one is absent. Either of them, their polycystic ovary is absent. Here, hirsutism is not present. So these are the different phenotypes: A, B, C, D, E, F, G, H, I. And in these, the metabolic disorder is invariably present. And then the patient is maybe hyperinsulinemic with metabolic syndrome seen in 42.3% of the women, and type 2 diabetes in around 3.6% of the women. So we have to be very careful while we are treating an adolescent who had come at puberty to us, or maybe an adult, or maybe a girl, young girl at 20 or 21, and then she might be here with us at 30, at 40, at 50, at 60 also. We have to keep our eyes open for polycystic ovarian disease. Polycystic appearances could be hyperandrogenism, acne, hirsutism, acanthosis nigricans, and alopecia, and the patient goes to dermatologist or endocrinologist. Insulin resistance, hyperinsulinism, patient again goes to diabetologist. And with worsening follicle qualities, reaches an IVF specialist. With menstrual disorders and oligoenovulation and infertility, goes to a gynecologist. And if you have a psychological problems and depression, then she goes to a psychologist. So it's a multidisciplinary team which has to get together and do the best for this girl who has come to us, who is suffering from polycystic ovarian disease. So what are the epigenetic factors in perinatal infancy? Congenital virilization, that hyperandrogenism, the fetus is exposed to maternal hyperandrogenism in utero, and the baby can be born with IUGR, maybe large for gestational age, maybe having a rapid growth, catch-up growth in infancy, in childhood, premature adrenarche, atypical puberty, and metabolic syndrome is setting in. Even at that age, you can imagine in childhood, when metabolic syndrome is setting in, then what is her prognosis in the later life? In adolescence, hyperandrogenism, and ovulation, polycystic ovary, and metabolic syndrome. And all of them can present with obesity. So that is the biggest worrying point. Mothers see chubby, but as a clinician, we should be wary of any chubby babies entering and visiting our clinics. So insulin resistant patient could be an android obesity patient, could have insulin resistance, genetically programmed hypersecretion of androgens from the ovary, leading to insulin resistance. And this leads to lipid storage, increased lipid storage, and altered fat metabolism, hyperinsulinemia, altered steroid hormone metabolism, promotes LH binding to receptors, increasing IGF pathways of androgen production from theca cells. And thus we have the clinical presentation of a polycystic ovarian disease, which is acne, hirsutism, hyperandrogenism, and infertility. So again, the etiopathogenesis is the same: genetics, lifestyle, genetics contributing by hormonal changes, lifestyle again contributing by obesity, and the epigenetics is binding the two, because epigenetics is the one, if we take care of epigenetics, the genetics can be suppressed, and then we can keep the disease at bay. Where this epigenetics comes into play, the patient may present with a low-grade inflammation. Hyperandrogenism is there, insulin resistance is there because of obesity, and hyperandrogenism also might be leading to insulin resistance. And hyperandrogenism clinically presents as hirsutism and acne, reproductive oligoenovulation, menstrual irregularity, and subfertility, and metabolic syndrome because of obesity and impaired glucose tolerance and increased cardiovascular risk factors. Psychosocial issues are there because of body image, self-esteem, because of hirsutism, depression, and anxiety, and because of obesity as well. So the girl has to be really taken care of. We have to counsel her that we are looking for a treatment which will last in ages, she has to be counseled and counseled that the disease can come under control, cannot be cured, and she has to be under supervision with drugs or without drugs. So this is another schematic representation of pathophysiological mechanism of polycystic ovarian syndrome. And again, this is again a summary that environmental factors and genetic factors, if they lead to inositol deficiency, there could be a deranged insulin signaling. So this is what we are focusing at, inositols, and then pituitary dysfunction, enhanced ovarian androgen production, and development of insulin resistance. So they all are, they form a vicious cycle, each of them supporting each other, and the base is inositol deficiency, which is being played upon in a girl who has a contributing environmental and genetic factors. So symptoms and frequency, menstrual cycle disturbance is seen in 70%, 50% come with oligomenorrhea and 10% with amenorrhea. Irregular heavy bleeding in 10 to 15%, and hyperandrogenism is seen in 70%, presenting with acne in 30 to 40, hirsutism in 70%, alopecia as seen by gynecologists in 10% women, and acanthosis nigricans in 1.3%, lean and 20% obese women. So we have lean PCOS also. Obesity accounts for 50 to 60% patients. Normal menstruation, so the rest would be lean also. Normal menstruation is seen in only 20% of the patient, infertility in 70%, pregnancy loss is 50 to 60%. Early pregnancy losses we are looking at. And this is very pathognomic of polycystic ovarian disease, because probably it seems to be because of impaired insulin metabolism. And that is the reason why we have to be very aware that the patient might has to be put on insulin sensitizers and carry those insulin sensitizers in the pregnancy as well to keep her pregnancy from aborting. So cosmetic concerns, alopecia in 10%, dermatologists feel it's not all that uncommon. And acanthosis nigricans is seen in 1.3% lean and 20% obese women. So the test needed to diagnose hyperandrogenism would be total testosterone and 17 alpha hydroxyprogesterone levels. These are levels done to rule out late onset congenital adrenal hyperplasia. Free testosterone and free androgen index have no role. So we have to be very careful. We are doing total testosterone, not free testosterone, which comes in minuscule amounts, and it's a very sensitive test which has to be validated by a well-established lab with proper standards, which we do not get each and every time. So don't go for free testosterone, go for total testosterone. And it is 10 times costly and not a standard in all labs. An endoscopy biopsy is not required.
Sorry, ma'am, for the interruption. Some sound is
Your
not.
voice is not clear, ma'am.
My voice is not clear. Is it okay now?
Yeah, it's okay.
Now it's okay.
Okay. So 17 DHEAS varies from 100 to 350 milligrams per deciliter, and 17 hydroxyprogesterone has to be done in a follicular phase. The values are 30 to 200 nanograms per deciliter, and over to 800 nanograms per deciliter is a diagnostic of adult onset congenital adrenal hyperplasia. So these are the, again, it's the same thing that in adolescence, persistent elevation of total testosterone, hirsutism, and moderate to severe acne. Oligoanovulation and polycystic ovarian volume could be greater than 12 centimeters per square in good machines. So persistent oligomenorrhea for at least 2 years after menarche, and primary amenorrhea by age of 16, and complete pubertal development. So on ultrasound morphology, we have said that it should not be used for diagnosis of PCOS in a girl who is 8 years, less than 8 years after menarche, due to high incidence of multifollicular ovaries in this life stage. So practically in adolescents, that means we are skipping an ultrasound to document a polycystic ovarian disease. Using endovaginal ultrasound transducers with a frequency bandwidth that includes 8 megahertz, the threshold of a PCOM should be on either ovary a follicle number per ovary of greater than 20, or an ovarian volume greater than 10 ml. ensuring no corpus lutea is there, cyst or dominant follicles, that is any follicle greater than 10 mm. Everything, all these follicles have to be between 2 to 9 mm. In patients with irregular menstrual cycles, hyperandrogenism, and ovarian ultrasound is not necessary to diagnose PCOS, because we are taking two criteria in Rotterdam. So if the patient has irregular cycles and hyperandrogenism, which is clinical or biochemical, maybe or maybe not, you need an ultrasound to diagnose. You don't need it, but you might need it for your own documentation and follow-up of the patient. So clear protocols are recommended for reporting follicles per ovary. We have to look at last menstrual period, transducer bandwidth approach or root assess, maybe a TVS, or we are doing an upper abdominal. Total number of follicles is around 2 to 9 mm, 3-dimension and volume of each ovaries. Reporting of endometrial thickness and appearance is preferred. A 3-layered endometrial assessment may be useful to screen endometrial pathology. Other ovarian and uterine pathologies as well, ovarian cyst and corpus luteum and dominant follicles, we have to rule out any dominant follicle greater than or equal to 10 mm, which is not included in the count. So these are the 3D ultrasound. These are very advanced ones, 3D manual mode, sono. This is automatic volume counter. So these are all costly machines. And with these, we are looking at around 25 follicles. Then anti-Mullerian hormone. It's a serum AMH levels should not be used as an alternative for detection of PCOS as a single test for the diagnosis. And it's an emerging evidence that improved standardization of assays and established cutoff levels or thresholds based on large-scale validation in populations of different ages and ethnicities. AMH may become assays will be more accurate in detection of polycystic ovarian morphology. So again, these are the complications in infertility. Primary infertility reported in 50%, secondary in 25%. In obstetric, 3 times higher risk of preeclampsia, GDM, 2-fold increased risk of preterm deliveries and IUGR. Cardiovascular risk, these are all metabolic risks. And a cardiovascular, 2-fold increase in MI and 2-fold increase in hypertension, 5 to 10-fold increase in risk of developing type 2 diabetes, and increased risk of endometrial cancer, and psychological, 4-fold greater odds of depressive symptoms, high prevalence of anxiety disorders, and reduced quality of life. So these are the clinical features and points to remember, just to rethink about them. And oligo-ovulatory and anovulatory cycles resulting in continuous endometrial stimulation with estrogens, causing endometrial hyperplasia, thus increasing the risk of endometrial cancers. In all the women who are above 40 years of age, we have to be very careful. Acne in PCOD, complaints of inflammatory acne, minimally responsive. These acne are responsive mainly to hormones. Even if responsive lesions promptly recur on stopping treatment, development of multiple closed comedones will rapidly transform into tender lumpy nodes distributed in the lower half of the face and jawline. These tend to persist beyond the usual course of 5 to 7 days because they are being driven by the hormonal irregularity background. A premenstrual flare-up is also common. Acne lesions may be present on chest, shoulders, and back. Prompt release after stopping the treatment strongly suggests a hormonal basis. Then hirsutism, excessive facial hair is normal racial trait for Indian subcontinent, acting via androgen receptors and secretory factors. Androgens increase the growth rates, diameter, and melanization of hair in androgen-sensitive areas. These thick, coarse terminal hair in androgen-dependent areas point to an underlying hyperandrogenic state. And this is evaluated by modified Ferriman-Galway score, which evaluates 9 body areas on the scale of 1 to 4, and a total score is significant if it is more than 6 to 8. And acanthosis nigricans and alopecia, typically thick, dark, velvety skin situated on the nape of the neck, axilla, groin. These are the folds, and other frictional areas may be seen as the first clue of insulin resistance, and acanthosis as acanthosis nigricans. Not all cases of female pattern hair loss may be of androgenic origin. Pattern hair loss in PCOS may be difficult to distinguish from those secondary to other hyperandrogenic states. So we have to be aware that the symptoms, the signs are overlapping other diseases as well. So as we go on treating a patient of polycystic ovarian disease, so we have to be aware all the time, keep on reevaluating her for other diseases as well, as she keeps on coming to us. We just can't sit on our diagnosis of PCOS, or we can't sit on the diagnosis of any other diagnosis which we were putting as differential diagnosis and rule and miss PCOS. So again, these are the clinical features. And in adolescent, insulin resistance, obesity, hyperandrogenism, and perimenopause, infertility, premenopause, sorry, hyperandrogenism, obesity, prediabetes, hypertension, dyslipidemia, metabolic syndrome, obstructive sleep apnea in obese women, depression, anxiety, endometrial cancer, and postmenopausal cardiovascular disease, obstructive sleep apnea, endometrial cancer, and depression. So these are all signs and symptoms, and they are predisposing a woman to a disease, not only signs and symptoms, to a big disease in which she is at a risk for so many other follow-ups. So she has to be followed up with all a metabolic syndrome. The risk factors of metabolic syndrome include central obesity, hypertension. Central obesity is important because this represents the fat which is getting deposited around our internal organs. Peripheral obesity is what we see on arms and legs and peripheries. But central obesity is basically representing fat getting deposited in and around our vital organs like liver, kidneys, peritoneum, and omentum. So that is the reason why it presents at central obesity, hypertension, atherogenic dyslipidemia, insulin resistance. And it affects around 33% of women with PCOS. Consequences could be cardiovascular disease, type 2 diabetes, cancer, sleep apnea, and psychological problems. So these are again the same things presenting in a diagrammatic way. So the management would be a multidisciplinary team, lifestyle plan and support treatment of hyperandrogenic symptoms, endometrial protection, contraception and fertility, psychological and behavioral support, nutritional counseling, metabolic screening and intervention. Always, whenever the patient comes to us, we have to be on guard and looking for metabolic symptoms, signs and symptoms, so that she can be counseled well in advance and keep the diseases at bay for as long as possible by modifying her lifestyle. So, and these are the pregnancy or ovulation induction is desired. These are the various lines of treatment. If there is an ovulation, we look for clomiphene. Second line would be metformin. If there is an insulin resistance, the first line would be metformin. Obesity, first line would be my lifestyle modification and hirsutism. Then if she wants pregnancy, we cannot use drugs which are anti-androgenic. So the first line treatment is electrolysis and light-based therapies. These are for cosmetic effects, acne, topical creams, and antibiotic and benzoyl peroxide. We cannot use tretinoin when the patient wants to become pregnant. At least for 3 months, if she's on tretinoin, she should avoid pregnancy for 3 months because they are known teratogenic agents and they are absorbed. So be very careful. If a patient who's on acne treatment and she conceives, by default, we cannot carry that pregnancy in any case. So if she doesn't want pregnancy, then for the first line for treatment for anovulation and menstrual irregularities would be COCs, including LNG. And second line would be metformin, insulin resistance, same metformin, obesity, lifestyle. Hirsutism could be hormonal contraception with or without an anti-androgen. Second line would be spironolactone monotherapy, electrolysis, light-based therapies, eflornithine or finasteride, and third line would be metformin. And in acne, again, first line would be hormonal contraception, topical cream, including benzoyl peroxide, tretinoin here can be used, adapalene or antibiotic cream, and second line would be spironolactone. So this is the way, the basic chart we form, how we are treating the patient who's presenting. So these are the different drugs. That clomiphene is for ovulation induction, eflornithine, it's a local agent which inhibits hair growth. Finasteride and flutamides, these are again anti-androgens, hormonal contraceptive, pill patch and vaginal ring. Letrozole is again a ovulation induction drug. LNG, which is an intrauterine device preventing against hyperplasia. Metformin is an insulin sensitizing agent. Spironolactone is anti-androgenic and mineralocorticoids. They all have their main side effects, and we have to be very, very particular where we are using them, how we are using them. And we have to be very careful with all these drugs because this flutamide has got hepatotoxicity, liver toxicity, and finasteride It has hypersensitivity reaction and decreased libido. So we have to be careful where we are using them and how we are using them. So we are treating symptoms. So that was the crux of the chart I had shown you earlier, that we are treating the symptoms, not the cause. So the cause, again, we go back, it is probably insulin dysregulation, maybe the production or maybe the function. So in the current armamentarium, we have insulin sensitizers, metformin or pioglitazone. It is making a comeback. And anti-androgens, spironolactone, sapropterin acetate, flutamide, finasteride. OCPs as oral contraceptives, ovulation inducers, clomiphene and letrozole and estrozole, cosmetic, laser hair removal, bariatric surgery and acne therapy, and others are laparoscopic ovarian drilling and statins. So for hormonal imbalance like hyperandrogenism, LH, FSH imbalance, the patient might be presenting oligoamenorrhea and ovulation. In metabolic imbalance, there would be insulin resistance and dyslipidemia. We will get impaired glucose tolerance and obesity. So basically, till now, we are treating the symptoms because these symptoms are complex in presentation, and together they are very detrimental to our patient's health. So the management of PCOS, there are different guidelines. The guideline 1 saying screening, diagnostic assessment, and life stage and adolescents. Guideline 2, prevalence, screening, diagnostic, and management of emotional well-being. And guideline 3 says a lifestyle change, pharmacological treatment in PCOS for non-fertility indications. And guideline 5 says the screening, diagnostic assessment, and management of infertility. So these are international evidence-based guidelines for the assessment and management of PCOS. So lifestyle change could be diet, exercise, weight loss, behavioral changes, and smoking cessation. It has to be multidisciplinary team approach involving a clinician, dietitian, exercise specialist, and a counselor. So we have been reiterating it again and again. It's a multidisciplinary team because it has got multiple symptoms and signs. They have to be treated. Weight loss in PCOS, a 5% weight loss will reduce insulin resistance and circulating androgens, resulting in spontaneous ovulation and improvement of symptoms. And the patient should be very happy that we are asking her to become more healthier than her obese self, and she will improve in her body language, body image, and self-consciousness. Women with WHO group 2 and ovulatory infertility with PCOS who have a BMI over 30, weight loss alone may restore ovulation, improve response to ovulation-inducing drugs, and have a positive impact on pregnancy outcomes. So this is very important. She should understand that once by hooks or by crooks she becomes pregnant, she would not be able to lose weight. So it is better to enter pregnancy with a weight loss. And diet, creating a calorie deficit of 3,500 to 7,000 per week for weight loss. Spread the calories throughout the day by having 5 to 6 small meals. Food with low glycemic index, carbs, longer to digest, cause low and slow rise in blood glucose, and thus insulin levels are regularized. Vegetable, legumes, and fruits have a low GI rating, and refined carbohydrates to be avoided. So cholesterol intake has to be minimized. Whole fat dairy products such as butter, ghee, whole milk. Cholesterol should be less than 300 milligrams per day, and use low fat cooking methods like baking, broiling, grilling, boiling rather than frying. Exercise, we have to remember this acronym FIT VP, that frequency of exercise should be 5 days a week. Intensity should be moderate, and type is aerobic exercise, 30 minutes per day, 150 minutes per week. And in progression, start low, go slow with moderate intensity. Because if you do not start low, then you start getting disheartened and you keep on looking at your weight every other day. Your weight is not going to decrease unless you have negative energy balance. So the treatment in obese patients, weight reduction, diet plus exercise, this is a lifestyle modification. So diet and exercise is not for a temporary, like she has to get married, she's going on diet and exercise, and as soon as she gets married, she just leaves it like that. So lifestyle modification means that whatever changes in diet and exercise she is undertaking, they have to be carried out throughout her life. Weight loss of 2 to 5% reduces testosterone by 21% and resumes regular ovulation in 50% of the women. So 2 to 5% of the women, 2 to 5% weight loss in 50% of the women, they would not need any ovulation induction drugs. most important long-term treatment in obese females. Other general lifestyle factors like avoid alcohol, smoking, and psychosocial stressors. Managing menstrual disturbances. If the patient does not wish to conceive, medical therapy is directed towards interruption of unopposed estrogen on endometrium. Non-fluctuating levels of unopposed estradiol in absence of progesterone causes irregular bleeding, amenorrhea, infertility, increased risk of endometrial cancers. OCPs, higher dose OCPs may elevate risk for cardiovascular diseases and may be also associated with dyslipidemia and increased chance of thromboembolic events. And evidence suggests that there is increased risk of type 2 diabetes mellitus with higher dose OCP usage. And a low dose oral contraceptive pill has to be recommended, which can be used over a long period of time. So managing hirsutism, all anti-androgens, spironolactone, 25 to 100 milligrams BD, and has to be titrated to balance efficacy. Cyproterone acetate is another one, flutamide, finasteride, they all have their own. Flutamide is hepatotoxic, so we have to be very careful while using it. Finasteride also has been used. Ornithine decarboxylase, these are efluornithine, these are the creams which are available and can be applied topically. Mechanical and cosmetic means of hair reduction and destruction, like shaving, plucking, waxing, depilatory creams, electrolysis and laser hair reduction. These all we have to tell the patient that hirsutism is being driven by hyperandrogenism. All the drugs will help her as long as she is taking the drugs to suppress her hyperandrogenism. The moment she leaves, hirsutism is bound to come back. So she has to be counseled and counseled. She takes whatever treatment suits her, but then she has to be counseled that it is bound to come back when she stops the treatment. And that counseling is very, very essential, and especially in skin clinic, because they are undertaking very, very high, expensive end treatment, thinking that laser and all will be a permanent thing. Nothing is permanent. They are all hormone driven, and they are bound to come back. So managing menstrual disturbances and I've gone back. Medical ovulation, treating anovulatory. Medical, we have ovulation induction drugs. First line treatments would be anti-estrogenic, that is clomiphene citrate. And we have second line is exogenous gonadotropins. Letrozole also can be tried. It is becoming the first line drug nowadays because there are multiple follicles and we want a monofollicular development where letrozole comes in. Strong evidences confirm inositols in restoring fertility in polycystic ovarian patients because there is a imbalance of inositols. And surgical would be laparoscopic ovarian drilling, and it is a secondary second line treatment in infertility. Multiple pregnancy rates are reduced in women who are having ovarian drilling. In some cases, fertility benefits of ovarian drilling may be temporary, and adjuvant therapy after drilling might be necessary with clomiphene. And ovarian drilling does not appear to improve metabolic abnormalities. So we have to be very careful that ovarian drilling is for ovulatory dysfunction. And the hyperandrogenism could be because related to ovary as well as adrenal gland. And if although in a polycystic ovarian disease woman, the hyperandrogenism is from the ovaries itself, but ovarian drilling does not affect the stroma from where these are being driven. So basically, her hyperandrogenism might or might not reduce. So we have to be careful that we have to look at her other parameters like metabolic parameters. Letrozole should be considered as a first-line pharma treatment for ovulation induction and PCOS with anovulatory infertility and no other infertility factors to improve ovulation, pregnancy, and live birth rate. Letrozole is not available or use is not permitted or cost is prohibitive. Health professionals can use other ovulation induction agents. These are recommendations from Green Top guidelines. And health professionals and women need to be aware that the risk of multiple pregnancy appears to be less with letrozole than to clomiphene citrate. And again, these are evidence-based recommendations. Clomiphene citrate should be used alone in women with PCOS with anovulatory infertility. And metformin could be used alone, again alone in PCOS with anovulatory infertility. And if metformin is being used for ovulation induction in women with PCOS who are obese, that is BMI over 30 kilogram per meter square, but in India, we are using 23 and a half BMI to be excess, and internationally it is 25. So over here, we'll again decrease 2.5, that is 27.5 kilogram per meter square. With anovulatory infertility, no other infertility factors, clomiphene could be added. And clomiphene citrate again should be combined with metformin rather than persisting alone with clomiphene. In women with PCOS who are clomiphene citrate resistant with an anovulatory infertility and no other infertility factors to improve ovulation and pregnancy rates. So in essence, it says either we use alone clomiphene citrate, alone metformin, or the combination of two. So the concerns about metformin, adverse effects including gastrointestinal side effects that are generally dose dependent and self-limiting, and starting at a low dose with 500 milligrams increments 1 to 2 weekly and using extended release formulations may minimize the side effects. And metformin appears to be safe long-term based on use in other populations. However, ongoing requirement needs to be considered, and use may be associated with low vitamin B12 levels. And use is generally off-label, and health professionals need to inform the woman and discuss the evidence, possible concerns, and side effects. So the gonadotropins, these are another evidences that there's a lot of disturbance. Kindly mute the other participants.
Ashish, Sheena, please.
So gonadotropins, kindly mute, sir.
Yes.
Gonadotropins could be used as a second line pharmacological agents in PCOS who have failed on first line oral ovulation induction therapy, and could be considered as first line in presence of ultrasound monitoring following counseling on the cost and potential risk of multiple pregnancy. And gonadotropins, where available and affordable, should be used in preference to clomiphene citrate combined with metformin for ovulation induction in PCOS women with anovulatory infertility, clomiphene citrate resistance, and no other infertility factors. And gonadotropins will be, with addition of metformin, could be used rather than gonadotropin alone in PCOS. And either gonadotropins or laparoscopic ovarian surgery could be used in women with PCOS and anovulatory infertility. So these are the other evidence-based recommendations where we can use gonadotropins, maybe as a first line where the patient can afford it, maybe as a second line when she's having clomiphene citrate resistance, and we can add metformin along with it. Laparoscopic ovarian surgery could be a second line therapy for women with PCOS who are clomiphene resistant and anovulatory infertility with no other infertility factors. And ovarian surgery could be potentially offered as a first line treatment if laparoscopy is being done for another reason in a woman with PCOS and ovulatory infertility and other infertility factors. But we have to counsel the woman, and the surgeon should also be counseled himself that we have to be aware of the AMH levels, which might decrease post-surgery, and we might land up into premature ovarian failure. So we have to obviously balance when we are doing a laparoscopic surgery, we are doing a drilling or not. So inositols, as these are food supplements basically belonging to vitamin B complex group. Inositols levels are very low in PCOS patient, as evidence is seen in blood. The parameters in PCOS, the levels are low, and urinary clearances on the higher side. So the functions of inositols as a signal transmission and a secondary messenger, it acts as an intracellular calcium concentrations, on metabolic effects because of insulin signal transduction, and it modulates serotonin activity modulation and nervous system regulation and gene expression as well. So these are the other abnormalities. We are again focusing on a picture of a metabolic syndrome, increased androgen production, and reduction in hepatic SHBG release. These all are causing different pictures of polycystic ovarian disease, and where these are the places where myoinositol and a combination of dichloroinositol and myoinositol can act. That the combination can help in reduction of hyperandrogenism, and only myoinositol can also decrease increased androgen production. So where we are looking at balancing all these hormonal abnormalities and thus getting a correction without treating the patient with steroids or maybe these LH and gonadotropins and all. So thus we can think of putting the patient on either plain minoxidil or a combination of D-chiroinositol and myoinositol, and thus getting her relieved from her polycystic ovarian disease, and at the same time taking care of her metabolic syndrome as well. So inositol and phospholipid calcium as a secondary messenger. We have oocyte evaluation, oocyte maturity, and fertilization. So MIDCI in PCOS, insulin resistance, when we are giving MIDCI in a proper combination of 40:1, it normalizes insulin signaling and glucose metabolism, thus reducing insulin resistance. Inflammation of the ovary and goes down, theca cells come down, androgen levels come down to normal, and thus fertility is restored. And also it is acting on LH levels, which come down to physiological levels, insulin levels become normal, and weight loss starts. And when the weight loss starts, the patient starts having a regular cycle. So MIDCI are playing a very, very crucial role in a patient who is having polycystic ovarian disease, and it is hitting at the base of the cause of polycystic ovarian disease, and thus restoring all the factors and keeping her metabolically safe as well. So MIDCI, we have already done in the treatment of teenagers. That is where the role of MIDCI, minoxidil, comes in the treatment of teenagers, because we have administration of MI safe and effective in preventing and correcting metabolic disorders in teenagers. Combining MI with OCP's anti-androgenic effects are enhanced, and negative impacts of OCPs are decreased. So these are the different presentation in an Indian scenario, where after giving MI, these are the study of effect of minoxidil on menstrual irregularities and skin problems in polycystic disease. It reduced from 31 to 7 oligomenorrhea, acne reduced from 15 to 10, and Ferryman-Galloway score reduced from 8 to 7. And the conclusions of the study are confirmed that minoxidil reduces insulin's resistance and improves menstrual irregularities in PCOS cases. This is again a meta-analysis involving, these are control trials in 247 cases. Significant decrease in fasting insulin was seen, significant decrease in HOMA index was seen, reduction in testosterone concentration, significant increase in serum hormone binding globulin was seen, and thus hyperandrogenism would be tackled. The trial of sequential analysis of insulin meta-analysis illustrates a firm evidence of improvement with MI and beneficial effects of minoxidil in improving the metabolic profile of PCOS women, concomitantly reducing hyperandrogenism. So we are tackling all the features of polycystic ovarian disease by using a single drug. So international consensus, experts have consensus that clinical data demonstrate efficacy of MIDCI in treatment of PCOS, and evidences suggest a strongest dose of 4 grams per day of MI when used alone. So 4 grams per day is the optimal dose. And when we are using the combination, the optimal ratio would be 40:1. And taste and acceptability has to be there for the patient to give us a compliance. The formulations and tablet and capsules have a lower absorption and can alter efficacy. So if we use a powder form, then the results would be better. The inflammatory markers, circulating inflammatory markers in PCOS, a study was done and it was seen that gut permeability is increased, leading to metabolic endotoxemia, and these two together cause rise in CRP, TNF-alpha, and IL-6. These are cytokines which are very harmful for the body. TNF-alpha causes phosphorylation of insulin receptors, protein, leading to insulin resistance. In lean PCOS, the leaky gut causes increase in TNF-alpha and IL-6, and they have been linked to insulin resistance. Endotoxin, lipopolysaccharides in the systemic circulation leads to increased fasting glucose and insulin levels and resistance. And human studies have provided that good gut microbiota improves insulin sensitivity. So gut dysbiosis also is playing a big part in PCOS. So this is dysbiosis of the gut microbiota, increase in gut mucosal permeability, lipopolysaccharide from gram-negative bacteria enters the systemic circulation, activate the immune system, induce low-grade chronic inflammation, interferes with insulin receptor function, increasing insulin resistance, increase in ovarian androgen production. So alpha biases, and thus it results in reduction in the production of all the cytokines. So the peak plasma concentration of MI with ALAC and MI alone, it was seen with ALAC, the peak plasma concentrations of MI also improved because gut reabsorption is improved. That is, intestinal absorption is improved in vivo. So effect of myo-inositol plus alpha-lactalbumin in myo-inositol resistance PCO women was studied in this study, and maximum ovulation rate when only MI was given, it was seen to be 62%. Along with ALAC, it resulted in 95% ovulation because the dose of MI, or the bioavailable MI dose increased. So the reduction in hyperandrogenemia was also seen. The percentage change in testosterone was 35% reduction. Free testosterone was 53% reduction. DHEA was 47% reduction, and SHBG increase was seen in 92% of the patients who were on MI and ALAC combination. The expert opinions on inositols in treating PCOS and non-insulin dependent diabetes mellitus a further help for human reproduction and beyond. So this is an opinion from Drug Metabolism and Toxicology. The combination of MI and alpha-lactalbumin was found effective in PCOS, and they are safe at therapeutic doses. US FDA included them in the list of recognized safe compounds. So the objectives, what is as a clinician, objective is to improve the quality of life. So we have to assess the quality of life and impact of symptoms. We have to improve the communication with the patient. Communication is the key because she has to understand. She keeps on going from doctor to doctor, and she says, the doctor gave me 3 cycles and I took the full course and I'm not treated. I'm still back to the same. They have to understand this is a lifelong disease and improve adherence to lifestyle changes. Adherence is the main word, and improve self-care, improve quality of life. So the counseling becomes the main crux of the treatment in a polycystic ovarian disease, especially in youngsters. So PCOS manifests in women at reproductive age when finding a partner, initiating sexual life, and forming a family are very relevant. Factors that negatively affect physical appearance of femininity or compromise fertility are sources of great anxiety and distress and can lead to imbalances and psychosexual sphere. Depression and anxiety are highly prevalent in women with PCOS, and it has been found to have 4-fold increase in prevalence of depressive symptoms in patients with syndrome compared with controls, even after adjustment for BMI. So this is very, very significant. So daily fatigue and sleep disorders, changes in appetite, loss of interest in everyday activities were the most common symptoms. Thus, the evaluation of quality of life in women with PCOS is essential for better care and clinical management of these patients. In conclusion, PCOS is a multifaceted condition. A multidisciplinary approach is required. Lifestyle modification, diet, exercise, and behavioral therapy are principles, are the base, are the foundations of the treatment. Low-dose gonadotropins can be used as a first-line agent, and they are affordable and accessible. And if IVF and ICSI indicated when previous interventions have failed, or tubal occlusion or male factor infertility is also there. Thank you. Any questions? I'll welcome all of them.
Thank you very much, madam, for this informative and in detailed discussion on this PCOS and ovulation induction. Right. And ma'am, meanwhile, I received a few questions. So if you allow me, then we can address that.
Yeah, definitely. Go ahead.
Sure. So ma'am, my first question is, does the PCOS go away if a lady loses her weight?
See, losing weight, like we have to think of PCOS as a hormonal disorder. And in general way, how we counsel the patient of diabetes and hypertension. The first is lifestyle modification with diet and exercise. With diet and exercise, the PCOS the complications of PCOS will stay at bay. She will become fertile. If there are 50% patients become ovulatory, her fertility is restored, and her metabolic disorders stay at bay. The disease per se does not go away. She has to adhere to her lifestyle changes throughout her life to maintain a healthy lifestyle and prevent a metabolic syndrome from creeping up anytime. Such patients, we can't label them as cured. We can label them as controlled. That one has to really understand. The clinician has to understand and make her patient understand that all the parameters will stay at bay and she will be considered stable. As we control a patient in diabetes, we control on diet. If she's not controlled on diet, then we go to drugs. Similarly, with PCOS, if she controls her symptoms and everything is acceptable on diet, we are happy. The disease doesn't go away. The disease, the basic is there because it's a genetically programmed disease.
Okay, thank you, ma'am. And then next question is, ma'am, what is your opinion on N-acetylcysteine in case of ovulation induction?
N-acetylcysteine is again a very good potent ovulatory, helping in ovulation and controlling the cysts, and it can be used as an adjuvant, not standalone.
Yes. Okay, ma'am. Ma'am, another question: what is the percentage of patients with PCOS having chance of developing GDM in the future? Is there any relation between these two?
Absolutely, there's a high chance. I think it was mentioned in the slide around 50%, or maybe a little, around 20 to 25%. And the patients are, because they are per se exposed to metabolic syndrome. So, and insulin resistance or insulin dysfunction being the base of PCOS. So that is the base of GDM as well. And having diabetes later on in life as well. So definitely a high percentage of cases could be having GDM and diabetes, type 2 diabetes mellitus in later stages of life.
Okay, ma'am. Thank you, ma'am. Ma'am, I could not find any other question. So if you allow me, then we can close this session.
Yeah, definitely.
So thank you very much, ma'am, for your valuable time in our platform. And it was a nice discussion on this topic on PCOS. And hope all the participants have got benefited with this. You know, as I can already see one appreciation from Dr. Deepa Gupta. She told that it's a very nice and informative talk. And another, ma'am, sorry to say, but another question I got from Dr. Shikha Sharma that cyperotyrone acetate helps for all the symptoms in a patient not willing to conceive. Its side effects clinically seem.
Cyperotyrone acetate, it's an anti-androgenic drug. So we have to understand where we are using it. If the patient is presenting with hyperandrogenism, maybe she has clinical or she has biochemical, then we are using it. Okay, and moreover, she doesn't want to conceive. Then we add cyperotyrone to an OC pill. Then we add cyperotyrone to an ethinyl estradiol and make an OC pill for herself, for this patient. So cyperotyrone acetate has a special place where we can use it. Okay, and in low doses, yes, the side effects are less. Standalone, yes, it has higher side effects and higher doses.
So, okay, ma'am, no other question, ma'am. Thank you very much once again. And we will look forward in the future also for such nice discussion as well. Thank you very much, ma'am, and good day, ma'am.
Thank you so much, ma'am. And we can expect some more webinars from your end, ma'am.
Definitely.
On that same topic or any different topic also you want.
Whenever.
So we are very happy to conduct a webinar with you.
Thank you.
Thank you so much, ma'am, and have a good day, ma'am.
Thank you.
Thank you, ma'am.